Yeah, good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all on today's session on a very interesting topic: diabetes reversal and remission. Is a diabetes reversal and remission is possible? Without drugs, a patient can manage his diabetes. On this topic, that our Dr. Sanjay Kalra will guide us and enlighten us. But before moving on that, I will like to announce the last week winners: Dr. Sanjeev Puri from Hoshiarpur, Dr. Manan Mehta from Mumbai, and Dr. Ashutosh Das from Tamluk. So thank you all the doctors that who took part in our quiz. Now I would like to introduce our Dr. Sanjay Kalra, President-elect, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everybody. Good evening also to Dr. Sanjeev Puri, who has logged in today, and congratulations for winning last week's quiz. We'll talk today about a topic which has so many questions associated with it. And every day in our OPD, I think we have patients who ask us these questions. Doctor, can my diabetes be reversed? Can I get rid of my diabetes? Let's see how to answer such patients. We'll talk today about diabetes reversal and diabetes remission. First of all, let us put the record straight. There is nothing such as diabetes reversal, but diabetes remission can be made possible, and especially in a small subset of patients. So we'll talk about that later. Now, in a language like Hindi, it is very difficult to find different words for reversal and remission. The patient will usually ask us, Doctor Sahab, क्या मेरी sugar जड़ से निकल जाएगी? Can I get rid of it from the root? That is reversal. Remission would be more akin to कि डायबिटीज को हम दबा सकते हैं, हम इसके जो गलत परिणाम हैं, the wrong or the unwanted side effects or after effects or downstream effects, we can take care of them, we can prevent them. So we can certainly try to get diabetes in remission. Even if that is not possible, we are certainly trying to prevent the complications of diabetes. This language is important because when we speak about cure or management, let us say I'm writing glimepiride metformin to my patient. If the patient thinks that is just a means of getting the glucose down, patient may be adherent, may not be adherent. But if I tell him, madam, or I tell her, madam, this medicine is actually meant to prevent the complications of diabetes. If you take this medicine, it will give you good glucose control and it will help prevent heart kidney disease. It will help ensure that you have a healthy and a happy kidney and heart, even 10, 20, 30 years from now. Now, suddenly, the patient begins thinking of health and happiness. The patient begins thinking of 30 years from now, and then the adherence level goes up. So, but let us come back to our topic, type 2 diabetes remission. There are 3 or 4 definitions globally for this. The best definition is it is a healthy clinical state, so it has to be healthy. If you are unhappy or unhealthy with a normal glucose value, that is not nice. The glucose value is just one part of health. The healthy clinical state is characterized by the achievement of HbA1c before target level. So the target level can be 7 for someone, it can be 6.5 for yet another. Maintained for at least 6 months. So you can diagnose remission only after 6 months. With or without continued use of lifestyle modification. Because actually we would encourage everyone to follow lifestyle modification. Even metformin can be taken as a part of metabolic hygiene. Because see, so many people without diabetes are taking metformin. It is used in polycystic ovary syndrome. Some people use it for weight loss, yet others use it for gestational diabetes mellitus. Sometimes it is used in fatty liver. So with or without continued use of lifestyle modification and or metformin. Some people may even say that you can add SGLT2 inhibitor GLP-1RA to this. Because so often SGLT2 inhibitors are being prescribed now to non-diabetic people for heart health, for kidney health. So you might want to add that also to the definition. So type 2 diabetes remission is a healthy clinical state characterized by HbA1c below target for at least 6 months with or without the use of lifestyle modification. And this is debatable, with or without the use of drugs that may be used in non-diabetic individuals as well, like metformin, GLP-1RA, SGLT2 inhibitor. Provided that this A1C below target is not due to complications, comorbid conditions, or concomitant therapy. Let's take an example. Patient has got renal failure. Because of that, the HbA1c came down. But that is not a healthy state, so you cannot say remission. Comorbid conditions. Patient has got maybe gastritis, gastroenteritis, irritable bowel syndrome, inflammatory bowel disease, celiac disease. Patient is not eating anything at all. Because of that, patient is not taking any calories. This is not a healthy clinical state, even if the glucose level is normal. If patient is in starvation ketosis, patient is starving, patient is ketotic, even if the HbA1c is normal, that does not mean patient is healthy. And concomitant therapy, maybe patient is taking some long-term antibiotic, patient is taking quinine. Because of that, the glucose levels came down. That doesn't mean the patient is healthy. And even if glucose levels are normal, you cannot say that patient is in remission. So do remember, type 2 diabetes remission should be defined as good health along with good glucose value. Now our patients will ask us, Dr. Sahab, is diabetes curable? So the answer is no, not for type 2 diabetes. Gestational diabetes, of course, is self-limiting. After delivery, it will stop. But even then, you have to keep on following the patient up for dysglycemia for type 2 diabetes. It can recur. So GDM can recur. Type 2 diabetes can occur after GDM. Steroid-induced diabetes, again, it will stop once the steroids are stopped. But the dysglycemia can recur. And in type 2 diabetes, once it is diagnosed, it can recur anytime. But certainly, it is preventable. So what is preventable? Type 2 diabetes is preventable. The complications of type 2 diabetes are preventable. So, sir, madam, we can prevent things from worsening. We can ensure optimal health for you, provided you take the right medicines, follow the right physical activity and diet, and if required, reduce weight. Even 3 to 5% weight reduction will help in correcting dysglycemia. So all we need is 3 to 5% weight loss. Even if your waist doesn't move, your weight doesn't move too much, even 3 kg is more than enough for us. And this brings us to what we are aiming for. Of course, we are aiming for health. Now, earlier, the best that we would expect from diabetes management was improving the symptoms or maybe slowing the progression of kidney disease, heart disease. But now, actually, we can reverse also. So earlier, all we thought of was that microalbuminuria should not move on to macroalbuminuria. CKD stage 3 should not go on to CKD stage 5. But now with newer medicines, with finrenone, for example, uh, with linagliptin, for example, GLP-1RA, SGLT2 inhibitor, you can show that albuminuria can get reversed. It can come to normoalbuminuria. If that is possible, then even getting normoglycemia, euglycemia is also possible. And if you use the right drugs in the very beginning, then remission is possible. So now next question is, should I say this to all my patients or to a specific group of patients? And the answer is ABCDE. ABCD is coined by a doctor known as Lee et al. In India, we added E, ABCDE. ABCDE tells us which patients have greater chances of remission. So A for age of patient, if it is less, young adult. B for body mass index or body weight, if it is high and patient is willing to or able to reduce it. C for C-peptide. If C-peptide is adequate or high, it means patient has got type 2 diabetes. It is not type 1. There is adequate beta cell reserve. So low A for age, high B for BMI, high C for C-peptide or pancreatic reserve, and low D for duration of diabetes, if patient has recent onset diabetes. And E is for energy, enthusiasm, education, engagement of the patient, if patient is willing to do what it takes. So when a person who is newly diagnosed to have diabetes, 1 week, 1 month, 6 months, 1 year, 2 years comes to me and says, Dr. Sahab, is remission possible? The answer is yes. What will we do? We have to reduce diet. We have to reduce calories. If possible, reduce carbohydrates. And that is usually possible in an Indian diet. All this will help us in weight loss. If your BMI is above 40, maybe bariatric surgery. And now we have newer drugs which are calorie restriction mimetics. We can use those drugs, metformin, SGLT2 inhibitor, GLP-1RA. And we can use these drugs in such a way that your beta cells are not affected. Your beta cells get time to rest. So then patient will say, Doctor Sahab, how is this possible? I have been told that once diabetes occurs, it will occur forever. Once I take medicines, I have to take forever. So how is it possible? So the answer is, earlier we had drugs which would whip the beta cell. So the beta cell would of course get tired after some time. Now what we do is we use these drugs which help reduce your appetite, like semaglutide, liraglutide, dulaglutide, or which reduce the absorption of glucose from your stomach, like acarbose, or we increase the excretion of glucose from your kidney, like empagliflozin, dapagliflozin, canagliflozin. What all these drugs do in their own way, by reducing appetite, reducing absorption of glucose, increasing excretion of glucose, they reduce the glucose levels in the circulation. Now, this glucose in the circulation acts like a toxin. This is called glucotoxicity. So, right now you have high sugars. Your blood is being bathed by, and your blood is bathing every organ system of the body with glucose-rich blood, which is like a poison. If we take out this glucose, the blood will become healthier. Glucotoxicity will reverse. All the organ systems of the body, including the pancreas, heart, kidney, liver, lungs, will get better blood to bathe in, better nutrition, and they will come back to normal. And if to this we add a little bit of weight loss, a little bit of diet and exercise, we can bring the body back to near normal. We can get your diabetes in remission. There are different levels of remission as well. So, what are they? Metabolic remission is quite easy to do, provided you follow the right diet and take the right medicines. That is reversal of the insulin secretory defect or resistance. So you have metabolic improvement. Clinical improvement is that the A1C comes below target. Biochemical is that you are able to bring the A1C down below 6.4, 6.5, which is diagnosis of diabetes. If very lucky, complete remission below 5.7. That is the definition for pre-diabetes. And pharmacological remission is that you don't need any drugs now. So maybe HbA1c is, let us say, 6.9, right? That is clinical or partial remission. If HbA1c is 6.3, that is biochemical or complete remission. And if HbA1c is 6.3 or 6.9, without the need of any drug, like even metformin, that is pharmacological remission. So these different levels are there. We can aim for any of them. And once you aim for one, then you set your eyes on the next target. What are the strategies? We have spoken about them, but let's repeat. First is lifestyle modification, first and foremost. Reduce calories, reduce carbohydrates, but do not make them zero. Follow the advice of a trained medical nutrition therapy specialist and increase physical activity, minimum 30 to 60 minutes per day. Bariatric surgery will be required only if the BMI is more than 40. But some of the drugs we can use instead of bariatric surgery are, I already mentioned, the calorie restriction mimetics. So GLP-1 RA, like semaglutide oral, dulaglutide once weekly injection, or liraglutide once daily injection. These act on the hypothalamus, reduce appetite, and also reduce absorption from the gut. Acarbose and voglibose, especially acarbose, acts on the stomach, reduces absorption of carbohydrate. And SGLT2 inhibitors, cana, dapa, empagliflozin, increase excretion of glucose through the kidneys. So these are the drugs that we can use along with diet and exercise to help in diabetes remission. Diabetes remission is possible in real world practice, maybe 10 to 15% of patients. Patients do ask about it. So do not puncture their hopes. If they have type 2 diabetes, talk to them about A, B, C, D, E. Tell them that the focus should be on E, that is energy, enthusiasm, engagement. And also, it should be on B, body weight reduction. If the patient is already lean and thin, then there is nothing to be gained by going into starvation. Then you say, sir, right now, let us give you good glucose control. Let us bring the glucose values down. Once we have done that for 6 months, then maybe we can talk about remission. So you can just postpone the discussion to the future. There are some patients who will ask for surgery, and there is a lot of misinformation going on around this. So there are specific criteria. BMI more than 40, right? Or Adults with BMI between 35 and 40 who have significant comorbid conditions. If the social situation, the circumstances are such, psychological issues are such that patient needs surgery, then you can advise earlier. But don't rush to advise first. You can inform the patient about surgery and then talk to them about medical equivalents. GLP-1 RA would be the best. Tell them, let's give you a trial of GLP-1 RA for some time, maybe oral, maybe injectable, and then let's see how you behave, and then we can take a call later. Apart from that, there is a lot of discussion about physical activity, low carb diet. So, physical activity for every individual, whatever is possible based upon joint health, musculoskeletal health, but every day try to be more active than the previous day. Between low calorie and low carb diet, there is confusion, but both are good. But low carb does not mean zero carb. So, do not stop all carbohydrates. Do not encourage the patient to go on keto diet. So now, by now, we would have so many more questions in our mind. We'll take them one by one. But let us just remember 9 points now about diabetes remission. Uh, First of all, what kind of diabetes can go into remission? Not monogenic, not type 1. Only type 2 diabetes, the remission is possible, and that too in A, B, C, D, E. Stress induced hyperglycemia will resolve on its own if you correct the stress, physical or mental. So sometimes this is mistaken to be diabetes remission. A, B, C, D was D for duration of diabetes. So do remember that the earlier you begin treating diabetes, the more chances of remission. If patient is on long-term insulin therapy, then remission will not be possible. It means that the patient does not have any beta cell reserve. However, if patient has taken short-term insulin therapy for glucotoxicity, for some acute infection, inflammation, for some medical, surgical, or obstetric indication, then that doesn't mean that remission is not possible. In fact, it may hasten remission. Complications like liver disease, kidney disease, gastrointestinal disease, these can cause hypoglycemia. This does not mean that patient has gone into remission. Uh, Concomitant diseases like hypopituitary, hypothyroid, hypoadrenal, these can cause hypoglycemia. This does not mean that patient is in remission. And sometimes our patients will be taking glucose lowering drugs for non-glycemic indications. It might be liraglutide or injectable semaglutide for weight loss. It might be empagliflozin or dapagliflozin for heart health or renal health. Whether this will classify as remission, that is debatable. Weight loss is the first and foremost way to remission, so we should encourage that in everyone. Even 3 to 5% will help. And we should keep on reminding the patient that overall, our aim is not just to give you diabetes remission. Our aim is to give you happiness and health. It is to give you a healthy state. So focus on that. And do not try to go into starvation just to get that pride of remission of diabetes. Remain healthy overall. Ensure comprehensive health. So I hope we've been able to touch many of the questions and comments that come to our uh, mind in OPD. Let's take all the questions that we have, and lots of questions coming in. So warm welcome, of course, to Dr. Sanjeev Puri and Dr. VM Biradar. Hello, sir. It's good to hear you as well. And from Karnataka, we also have Dr. Gauri Shankar Dharmaraj. So question is 33-year-old patient with BMI 25, that is overweight. Osmotic symptoms are present. Newly diagnosed diabetes, A1C is 8.5. Yes, the chances of remission are there. The patient is young, so age is on our side. Patient body mass is on the higher side. He's overweight, so that is okay. C, we assume that there will be pancreatic reserve because A1C is just 8.5. And D, he is newly diagnosed, duration is less. In such a patient, we should start metformin, maybe DPP-4 inhibitor or GLP-1 RA. Because he has osmotic symptoms, we should postpone the use of SGLT2 inhibitors. First, let us correct the symptoms. Later on, we might wish to start SGLT2 inhibitor as well. If BMI is 8.5, this means we should start dual therapy. So I would, in this patient, start metformin plus DPP-4 inhibitor. Second choice would be metformin plus GLP-1 RA. GLP-1 RA will control glucose and also control polyphagia. After the patient has stabilized, then I may consider adding SGLT2 inhibitor also. In 6 weeks, I think this patient will begin going into hypoglycemia and we will have to reduce the dose. And we can tell him that there is 50-50 chance of remission. If you keep on doing your best, just follow a healthy lifestyle. We will try our best. Let us hope for the best thing. I see now that this patient also has melanopostitis. So SGLT2 inhibitor is out for now. Once we have corrected it with antifungal cream or tablets, later on we can start SGLT2 inhibitor. Dr. Nitin Rula says, how long we can take sublingual B12 deficiency daily? Yes, you can take maybe once a week for a few weeks, and then you test again 6 or 7 days after having taken the last dose. Maintenance should it should usually suffice with one tablet once in 14 days or once in a month. Daily, it will not be required. D3 is available sublingual. There are good brand names and they are effective. 60,000 units is available, vitamin D3. That the absorption is also good. Another case presented from Karnataka. This is 70-year-old gentleman with fatigue, malaise, and HbA1c 7.8. No other symptoms. Patient has fatigue only. So 7.8. If it were younger patient, we could start with dual therapy. Here we should start with monotherapy. So either metformin 500 milligram BD or a DPP4 inhibitor, linagliptin once a day or vildagliptin 100 milligram once a day or 50 milligram BD. Do look for blood urea also. Of course, you are saying there's no comorbid condition. So in this patient, maybe I would start metformin 500 BD or an SGLT or a DPP4 inhibitor, just one of these, and then see what happens. If glucose gets controlled in 2 to 3 weeks, fine. Fatigue will certainly improve. Give all the vitamins, nutritional optimization that is required. And if glucose doesn't come down, then we can give dual therapy. That would be metformin plus DPP4. Dr. Anshul Singh, warm greetings. And this is actually a difficult topic. You are right. Patients ask a lot of questions. From Dr. Suresh Shukla, a very pertinent question. Single kidney 30-year-old male with proteinuria, we can give SGLT2 inhibitor. It will be safe. It will be beneficial. So we can give. If patient has got active UTI or active genital tract infection, first correct it, then start SGLT2 inhibitor. If patient has history of pyelonephritis in the past, then SGLT2 inhibitor is contraindicated. Even if it is a history of pyelonephritis in the past, still we will not give SGLT2 inhibitor. Definition of remission, like I said, we can tell the patient metabolic remission, partial remission, complete remission, pharmacological remission. So we tell them, what I say is, I do not promise that the drugs will stop, but I am very sure if you cooperate, we will be able to reduce the drugs. So we'll climb the mountain and then we will come down. So this also you can define as remission for your patient. Patients are happy. So let us say I started with 6 tablets, 3 types of drugs. I am able to bring that down to 3 tablets, 2 types of drugs. That is also a partial remission. And then patients are very happy understanding this. Okay, tough question coming from Chhattisgarh. Is there a gap between the concept of remission and the way we define diabetes? Yes, there is a difference because definition and the comprehensive diabetes care. We follow comprehensive diabetes care, that is right. What is the aim of comprehensive diabetes care? Actually, patient has a right to choose. Some patients may just say, I want symptomatic relief. Others will say, I want good glucose control. Yet others will say, I want viscerometabolic, vasculometabolic benefit as well. So, of course, you try to explain everything to the patient and try to help the patient improve his or her aim and also try to fulfill that. But because the definitions of diabetes remission are quite modern and they are created by us. They are not created by physiology. Then when you use the word partial remission, you have a right to define it whatever way you want. That is on one hand. And on the other hand, the definition of diabetes, pre-diabetes, that is based upon evidence. So therefore, there is a gap. How we define diabetes and pre-diabetes is based upon the cardiovascular mortality, the morbidity, the vascular mortality, especially the retinal morbidity associated with HbA1c above 5.7 and 6.4. That is how diabetes and pre-diabetes was diagnosed, basically on retinal vascular health. And yes, a very important point from Dr. Anshul. Diabetes remission must be inclusive of vascular complications. That is why we say it is a clinically healthy state. This is a definition that comes from India, the one I shared with you. But our first line was clinically healthy. And you have to ensure that there is no complication, no comorbid condition, or no concomitant medication which is causing the uh, euglycemia. Otherwise, all our patients with renal failure will say that we are in remission, and that is not something that we want. So thank you, Dr. Anshul, for raising this point. It should be inclusive of vascular complication-free status. And to Dr. Vinayak Sharma also, good evening. We have more questions. Dr. Pramod Gupta says, can we use acarbose in pre-diabetes? The answer is yes. So beauty of acarbose, it is approved in pre-diabetes. In type 1 diabetes, you can use it along with insulin. In type 2 diabetes, also as a last resort, you can use in gestational diabetes as well. And it is a drug of choice for reactive hypoglycemia. So acarbose is one drug which you can use across the spectrum. I sometimes use it in pre-diabetes also in patients who have got high CV risk, because in the STOP NIDAM trial, acarbose was shown to reduce CV risk, improve CV outcomes even in pre-diabetes. Also, it helps prevent the onset of diabetes and prevents onset of other complications. And usually low doses will suffice, 25 BD, 25 TDS or 50 TDS. One very tough question from Dr. Vishnu Mulchandani, how to control hunger? Good question. How not to overeat any drugs? So first is lifestyle modification, mindful eating, meditation. Find a motive. You help the patient find a motive. The motive might be just, I want to fit into my favorite dress. It might be, if I just reduce my weight by 3%, I will reduce the chances of dysglycemia. If I reduce my weight by 5%, I will be able to reduce my blood pressure medication. Or I want to meet a loved one. It is Valentine's Day, of course, that has already passed. And I want to look fit and healthy and handsome so that I can give a good hug to my loved one on Valentine, maybe next Valentine. I want to go for a wedding. And so this is my motivation this week. I am going for my niece's wedding and I want to look good. We should look healthier and leaner than the opposite side. So first is meditation and finding a motivation. Second is how not to overeat. So some drugs are there. GLP-1RA would be the first choice. Second would be metformin and acarbose. These will actually help you. And one drug which you can use off-label, that would be topiramate, maybe 25 milligram OD, 50 milligram OD for a short period of time. Never more than 8 weeks, just 2 to 3 weeks, that will help reduce the hunger. Once patient is able to reset his or her hunger, hunger thermostat, right, barostat, then it becomes easier later on. You can use religion also, Dr. Mulchandani. So you can use religion as a motivational tool. So, madam, do you fast? Yes, I do. So then, if you can fast during Ramzan, why don't you try to control diet during the other 11 months also? So now now it is Rajab going on right now in the Arabic calendar, and then we will have in couple of days we will have Shaban. So, madam, why wait for Ramzan? Why not in Shaban only we start reducing our appetite and reducing our total caloric intake? If you are doing a fast every Tuesday, every Amavas, every Puranmashi, then why don't you extend that to other days of the week as well? Don't fast totally. Just try to reduce maybe one chapati. Try to reduce one bowl of sweet dish and try to take that as a fast or as an offering to God. Other questions are there also. So from Dr. Vilas Sonavane, warm welcome, sir. Patient on basal bolus, 888 basal bolus and 40 basal, having good glucose of control, having HbA1c 6.3. We can try, we can shift. So total units, let us count: 16, 24, and 40. That is 64 units. So 64 units, let us reduce 10%. So 64 minus 6, that becomes 58. So let us take an average of 55. So what I would do in this patient, I would say, let us try to reduce your dose. From 66, let us come to 56. Allow me to give something like 10 units in the morning, 10 units at lunch. This is a fast-acting insulin analog, maybe 5 as for Lispro, or aspart. So that is 10, 10, 20, and maybe 30 or 35 units of premixed, maybe biphasic aspart, maybe insulin degludec aspart, or a lispromix, whatever you wish is correct. Let us see how things go, and then after 2 weeks or so, we'll shift you to two dose, which will be premixed, biphasic aspart, uh, lispromix, or uh, uh, co-formulation like idegasp, and that will be something like 25, 25, 2 times. So we can easily shift this patient from 4 dose, you come to three, from three to two. Do remember that each pen or each cartridge will have 300 units. So if I am giving, let us say, 10 units twice a day of fast acting, that's 20. The pen will finish in 15 days. So I will call the patient back after 14 days. Let's see how you're doing. Maybe you will not need to buy that pen again. Dr. Sanjeev Puri says GIK regime, glucose insulin. Okay, glucose insulin infusion to control hyperkalemia. This is actually very, very useful. So if you have hyperkalemia, in the OPD they give potassium binders, but in such a patient you will give a dose which was earlier called neutralizing insulin. But in simple words, what we can suggest is, let us say your patient has got a glucose of 200 or more, and you want to control hyperkalemia, then you will give only insulin. So maybe you will start something like a normal saline with 6 or 8 units and give it 15, 20 drops per minute. So we are speaking simply, we are assuming that the insulin pump is not available. We are starting a simple trip. Normal saline with 6 or 8 units, start at 15 drops per minute. The moment glucose comes below 200, now there is a risk of hypoglycemia, but we still want to give insulin. Then we will shift to 5% dextrose plus insulin. Then I will give something like 500 ml of 5% dextrose plus 12 units of uh, regular insulin. So this units that Dr. Sanjeev Puri is saying is right. In 500 ml of 5% dextrose, there is 25 grams of dextrose. And I will start something like 12 units of regular insulin. I will keep on checking glucose every hour. But when I check glucose, I have to be mindful. I have to stop the drip for 15 minutes, then check glucose from the contralateral arm. I see what the glucose is like. If it is remaining around 150 to 200, I continue the same dose. If it is going up, then I will increase the number of insulin units. In the same drip, I may add 2 or 4 units more. But if the glucose is coming down, it is coming down to 100, then I have to stop the previous drip, start a new one. And here, instead of 12, I might give 8 units. We will give this for a few hours, and usually the hyperkalemia will get controlled. If you have an insulin pump, then it is much, much easier. Then, because in, let us say, 50 ml of normal saline, you will add maybe 10 units of insulin right at the beginning. Count the rate in units per hour. So 0.1 unit per hour, 0.2 units per hour, that is how we count it. And then you see how things move. But it is a good way of controlling hyperglycemia in hyperkalemia, and hyperglycemia, of course, also in the acute setting. More questions are coming, and thank you, Dr. Anshul, for raising that question. Actually, we should be thanking you. Dr. Arpan Agarwal says, father is 80-year-old, so namaskar, Uncle Ji, and thanks for taking care of yourself. Mixtard in the morning and evening, along with Emerald too. So actually, that is why hypo is occurring. We are giving Emerald, Glimepiride, along with Mixtard. First thing would be to stop Emerald. And since there is hypoglycemia, Agarwal Saab needs to shift to, I think the safest would be insulin degludec aspart. The same dose that you are giving of Mixtard, you shift to degludec aspart. The trade name is Rhizodeg. You can give immediately before or immediately after meal as well. And you will see that the hypoglycemia will come down markedly. In case glucose becomes high in the evening, then we may have to give a regimen like 5-ASP in the morning, 5-ASP in the afternoon, and degludec aspartame at dinner time. Here, how will you give the dose? The degludec dose will remain the same, degludec aspart at dinner, and the morning degludec aspart or mixed dose, you break it into two, equal parts at breakfast and lunch. So this will really help Mr. Agarwal, and it is much safer, much better. He will enjoy sleeping also. The quality of sleep will go up. But do stop Amaryl immediately, please. Also look for renal health. That is the commonest. In elderly people, simple urea creatinine may not tell you about renal health. So you have to do EGFR. You can calculate. All you need is the gender, the age, non-black, that is our ethnicity, and there are calculators. EGFR calculators are available online, free of cost. But please request stop glimepiride immediately and check renal function. And Dr. Sanjeev Puri, continuing with the question, when ketonuria disappears, for some time you have to give neutralizing insulin, because then when the patient is eating food, you give subcutaneous insulin. But subcutaneous will take some time to begin acting. 1 to 2 hours it will take to start acting. So until then, you keep on giving the neutralizing insulin. Glucose, insulin, potassium is the treatment, the infusion for hyperglycemia. Glucose insulin is the infusion for hyperkalemia. When you give insulin, it takes the potassium out, it reduces potassium levels. Imeglibin I have started using in my OPD, and actually there may be a role in diabetes remission. So no data as of now, but I have started using in newly diagnosed diabetics, and so far the results are promising, and I continue to use it. You can tell your patient that imeglibin will help to activate and increase the efficiency of the mitochondria, of the engines. So while you are exercising and improving your efficiency, while in the kitchen they are helping you take a healthier diet, maybe your mitochondria will also benefit. Sublingual B12 and D3 trade names. So my favorite sublingual B12 is Quickobal, Quickobal, and for D3, offhand I can think of Calcirol MDS right now. And thanks, Dr. Arpan, for that query. So these are the questions that we had today. This is a topic that is a very new topic for all of us, because earlier, before these new drugs were available, we did not have any concept of diabetes remission. The concept of diabetes remission was created by bariatric surgeons. But now that we have drugs which are calorie restriction mimetics, we can actually use our drugs also to achieve what we can call pharmacologically assisted or pharmacologically promoted diabetes remission. One last comment. Oh, this is a thank you. Thank you, Dr. Sanjeev Puri, from being with us. So thanks to everyone. And I hope you had a happy weekend, and we look forward to a happy weekday tomorrow. Warm welcome to Inamji as well. So with this, I'll hand over back to Team FDC.
Thank you, sir. I think, sir, you have taken a very new session. That's why we got a very long list of question answers. And thank you very much once again for taking all the question very patiently. And at the onset, sir, I would take the time to once again announce that we are in the 1 second, sir. Share screen. That's- We have designed the sessions for coming month, because coming month and this is the first time we are doing in our last 3 years ongoing journey with diabetes essential. For the first time we are opening this Ramadan session, and we have got guest speakers also in line. So on 5th of March, the topic would be Ramadan fasting and health, and the speaker is Dr. Sleha Sheikh. She is a consulting practitioner endocrinologist from Sepi Hospital, Mumbai. On 12th March, we will be having risk stratification and 1 second, risk stratification and pre-Ramadan counseling by Dr. Hamid Asraf. He's a professor in Aligarh Muslim University. And on 19th March, Dr. Sir Khalra Sir will himself will take the session, Management of Diabetes in Ramadan. So with this, I think we look forward to many of the guests joining more in the coming days and the entire month of Ramadan. And thank you, Dr. Sir, and Jai Hind, sir.
Jai Hind.
Thank you so much.